Hello and welcome back to the channel. It's been a little while since I've been able to create some more in-depth content, but I feel like today's topic is very relevant, and that is the management of pediatric respiratory conditions in the outpatient setting. These topics are definitely going to pop up on your board's exam, as I know I had multiple questions on these. But also, you will absolutely see these in your practice as well. Parents bring their patients in daily with respiratory complaints, and it's so important to know who requires an immediate transfer to the emergency department and then who can be properly managed in the outpatient setting. And then, of course, how to safely and effectively treat these patients. I will discuss symptoms of respiratory distress and then the diagnosis and management of pneumonia, croup, bronchiolitis, and then finally asthma exacerbations. As always, don't forget to support this channel by subscribing and then liking this video so that I can create more content like this. And now finally, without further delay, on to pediatric respiratory conditions. So I think it first makes sense to discuss the initial triage of a pediatric patient with a respiratory complaint, as this discussion will pertain to managing the pediatric patient with a respiratory condition in the outpatient setting. So right away, just laying eyes on your patient, you're going to learn a lot. What is the color of their skin? Do they appear dusky, pale, or do they have cyanosis? What is their effort of their breathing? Do they appear calm with even and unlabored breaths, or are they working to breathe? And what kind of things do we want to be looking out for when considering labored breathing? So there's things like nasal flaring, intercostal retractions, head bobbing, abdominal breathing, also tachypnea, and I will show you in a second here the normal values for respiratory rate in the pediatric population. And then finally, a low respiratory rate. And this is very concerning with our pediatric population specifically, as this can actually be a sign of pending respiratory arrest. And statistically, we know that respiratory arrest is the most common cause of cardiac arrest in pediatrics. And this is because children in respiratory distress can decompensate very quickly. And this is due to multiple factors, including a smaller airway anatomically, increased metabolic demands, decreased respiratory reserve, and then a less mature compensatory mechanism when compared to adults. And then, of course, while we are triaging our patient, we're collecting their other vitals, including their oxygen status, heart rate, temperature, and blood pressure in our patients 3 years and older. All right, so as mentioned previously, here are those values. I got this from UpToDate. It's the normal values for the pediatric respirations and heart rate, and it's just super helpful information when triaging those patients and then, of course, examining our patients and determining their level of severity of illness. If your patient is in respiratory distress, then hopefully you have a team of people, or at least a few people, that are able to work collectively and then simultaneously, as this is, of course, when our ABCs come into play: airway, breathing, and circulation. If a child is determined to be in respiratory distress in the outpatient setting, then priority is going to be stabilizing the patient and calling 911 to transfer them to the emergency department by ambulance. It's imperative to remain calm and try and keep the patient as calm as possible, as an increase in the child's anxiety, who is actively in distress, can actually make the breathing worse and, of course, increase complications. And then also the initiation of oxygen treatment, either by mask or nasal cannula, whichever the patient will tolerate more, is indicated while awaiting the ambulance to arrive. Okay, so assuming that our initial triage and examination of the patient indicates that they are not in respiratory distress and that they do not require a higher level of care, then let's discuss some of the most common respiratory conditions that you will likely see in the pediatric population. All right, so first up, we will discuss community-acquired pneumonia in the pediatric population. Pneumonia is an acute infection of the pulmonary parenchyma, or the portion of the lungs that involves gas exchange, predominantly being the alveoli, and it's potentially a very serious illness. This is often caused by the bacteria Streptococcus pneumoniae, but it is also can commonly occur from different viruses such as RSV or influenza. There is community acquired pneumonia, which is acquired in the community, for example, perhaps school, and then hospital acquired pneumonia, which, as the name states, is acquired in the hospital. So, symptoms of pneumonia include fever, generally 101.3 or greater, mildly increased respirations, a non productive cough, and then constitutional symptoms such as malaise and decrease in appetite. Also, decreased breath sounds or crackles may be auscultated over an area of consolidation. Generally, children less than 3 to 6 months with suspected pneumonia should be referred to the hospital for treatment and close monitoring. For those children that are 6 months and older with suspected pneumonia, empiric antibiotic therapy is warranted. So, diagnostic tools that are used to confirm a diagnosis of pneumonia include a chest x-ray, which of course can show a lobar consolidation, but also labs that support the diagnosis include an elevated white blood cell count and then possibly an increased ESR or CRP. Generally, the treatment of choice is high-dose amoxicillin, and that's 90 mg per kg, divided into 2 or 3 doses per day with a maximum of 4 grams a day. And the need for such a high dose of antibiotics is due to the concern for antibiotic resistance. Supportive treatment that includes fluid intake or increasing fluid intake, I should say, rest, analgesics for fever or discomfort. You can do acetaminophen, either 10 to 15 mg per kg, or ibuprofen, which is 10 mg per kg. Also, close follow-up is definitely indicated with these patients, typically within 48 hours from the first visit. If the patient's not improving in 48 hours, then you should consider changing antibiotics, as the pneumonia may be caused by a penicillin-resistant strep pneumonia. If this is suspected, then clindamycin is an appropriate alternative. The dosing for clindamycin for community-acquired pneumonia in the pediatric population is going to be 30 to 40 mg per kg, divided into 3 to 4 doses a day. And then follow-up should occur again within 48 hours of the antibiotic change to confirm that improvement is occurring. If the patient does not improve with antibiotics, alternative diagnoses should definitely be evaluated for. For example, a foreign body aspiration is another thing to be on the lookout for, or some kind of underlying immunodeficiency. And then a referral to a higher level of care, this is definitely going to be indicated in our patients that are not responding to treatment. And then I just included for your reference a couple of chest x-rays in the pediatric population with pneumonia. So on the left side of the screen here, this is a pulmonary opacity in the right middle lung. It's pretty easy to see there. And then on the right side of the screen here is a pulmonary opacity obscuring the left heart border. So there's just some examples for you to look at. All right, so next up I'm going to be discussing croup. Croup is typically a viral respiratory illness, and it generally affects the larynx and the trachea. However, it can extend into the bronchi. Croup typically occurs in children 3 months to 3 years, though it can occur in older ages as well. Symptoms of croup generally start with nasal congestion and drainage that evolves over 12 to 48 hours into a fever, hoarseness, a barking-like cough, and then even stridor. Symptoms typically worsen at night, and they normally resolve in 3 to 7 days. Symptoms of severe croup include signs that we've discussed in regards to respiratory distress, including intercostal retractions, significant stridor at rest, and then appearing anxious, agitated, or fatigued. Treatment for worsening, moderate, or severe croup includes a transfer, of course, to the emergency department by ambulance. While awaiting the ambulance, again, it's very important to remain calm and try and keep the patient as calm as possible, as frightening the child can actually worsen the symptoms. So other treatment options, they also include oxygen therapy and then nebulized epinephrine, and the ratio is 1 to 1,000 solution, and it's diluted in a 3 milliliter of normal saline, or there's premixed tubules of 0.5 mLs. Also, oral dexamethasone of 0.15 milligrams to 0.6 milligrams per kilogram with a maximum dose of 10 milligrams is indicated as well. So an IM, or an intramuscular injection of dexamethasone, this is not appropriate in this scenario because it, of course, is going to more than likely upset the child and worsen the symptoms. So if you can do it orally, then that is appropriate while awaiting the ambulance and transfer to the emergency room. Treatment for mild to moderate croup in the outpatient setting should again include dexamethasone for all symptomatic patients. And again, it's a single oral dose of 0.15 milligrams to 0.6 milligrams per kilogram with a maximum dose of 10 milligrams. And then another option includes a single dose of prednisolone at 1 milligram per kilogram. Additional treatment options again include the nebulized epinephrine, followed by a short burst of prednisolone, 1 to 2 milligrams per kilogram per day. By mouth, it's a single dose for 3 to 5 days, or also there is nebulized budesonide, and that's 0.25 milligrams per 2 mLs, and that's another 3 to 5 day treatment plan, though the nebulized budesonide has been shown to not be as effective in producing immediate results. So according to UpToDate, patients with mild cases of croup can be managed safely outpatient, and they generally do not require things such as nebulized epinephrine, though it is a tool to use if you feel that it is appropriate and indicated. Patients that can be safely discharged home, they have a return to normal respiratory rate and pulse ox. They are without dyspnea and they are without stridor at rest. They have a normal level of consciousness and they are able to tolerate fluids by mouth. Also, education is going to be very important for the caregivers of these patients that are returning home to care for a child with croup. They should be educated to closely monitor the patient and go to the emergency department if symptoms reoccur or if they get worse. If stridor reoccurs, we can educate the caregiver to sit with the child in a steamy room until symptoms improve. And then also, again, the nebulized budesonide treatments, they can do those at home as well. They can administer those once daily, or they can divide them into 2 doses. But again, the big important key factor here is educating them on when it is necessary for them to seek medical attention. All right, next up, we will discuss complications of RSV, or respiratory syncytial virus. RSV causes an acute respiratory tract illness in persons of all ages, and it typically causes seasonal outbreaks. Though it is the most common cause of lower respiratory tract infections in children that are less than 1 year old. There are multiple risk factors for the development of RSV, some of which include infants less than 6 months, particularly those who are born during the first half of RSV season, those who attend daycare, and then those who have older siblings, as they may have RSV and be actually asymptomatic. Additionally, patients with underlying lung disease, those with congenital heart defects, those patients that are exposed to secondhand smoke, premature infants born before 35 weeks gestation, those individuals with Down syndrome, patients with persistent asthma, and then those who are immunocompromised are all going to be at an increased risk of developing RSV. Direct contact is the most common route of transmission, along with droplet precautions. So contact precautions are pivotal in preventing the spread of RSV, and they are important to note, or it is important to note, that the virus can actually live for several hours on an individual's hands. So it's really important to educate on hand hygiene and how this is really effective in preventing the spread of RSV. So RSV can actually cause severe lower respiratory tract complications, including bronchiolitis, pneumonia, and then acute respiratory failure in children. So bronchiolitis, this is a clinical syndrome of respiratory distress that occurs in children 2 years and younger. So symptoms of bronchiolitis, these include a low-grade fever, rhinorrhea, cough, tachypnea, intercostal retractions, and then wheezing and crackles. So the treatment for non-severe bronchiolitis is going to include generally supportive care, and this is increasing oral hydration, relief of nasal congestion, rest, and then education for the caregivers is really important. So education, this includes the expected clinical course of the typical bronchiolitis. Generally, it begins with upper respiratory tract symptoms such as nasal congestion, and then on day 2 to 3, lower respiratory tract symptoms do develop. They peak on generally days 3 to 5, and then gradually resolve over the course of 2 to 3 weeks. So that's really an important education point, as this cough can last a long time. Other important education points include proper technique for nasal suctioning, and I went ahead and included that on the slide there for you. Avoidances of over-the-counter decongestants and cough suppressants, ensuring proper oral hydration, and indications to seek immediate medical care. For example, if the patient is experiencing episodes of apnea, cyanosis, poor feeding, new or worsening fever, increased work of breathing, a decreased in fluid intake, no wet diaper in 12 hours or more, and then marked lethargy. And again, the same rules as above apply. If a patient comes to an outpatient setting with symptoms of respiratory distress, unable to keep fluids down, or unstable vitals, then an immediate transfer to the emergency department by ambulance is going to be indicated. So finally, we will discuss the management of an asthma exacerbation. So the general guidelines for managing an asthma exacerbation include an early recognition of signs, assessment of the severity, timely intervention, and then a reevaluation after treatment. Symptoms of an asthma exacerbation may include breathlessness, tachypnea, wheezing, and the use of accessory muscles. Higher doses of the short-acting beta agonists are the treatment of choice for an asthma exacerbation. And this includes albuterol either by a metered dose inhaler or albuterol via a nebulizer. And dosing is weight-based, and it is as follows. The albuterol by a nebulizer is 0.15 milligrams per kilogram per dose, with a minimum of 2.5 milligrams and a maximum of 5 milligrams a dose. And this can be given every 20 to 30 minutes for up to 3 doses, and then 0.5 to 0.3 milligrams per kilogram with a maximum of 10 milligrams every 30 minutes to 4 hours as needed, or you could switch to continuous therapy. So that is a nebulized albuterol solution. And then albuterol by the inhaler, or the 90 micrograms per puff. This is weight-based dosing, so 5 to 10 kilograms, they can do 4 puffs, 10 to 20 kilograms, 6 puffs, greater than 20 kilograms, 8 puffs. Of course, this is for an exacerbation. And doses can be given every 20 to 30 minutes for up to 3 doses, and then every 1 to 4 hours as needed. So really, you can give it quite a bit if it's indicated. Of course, you can use a spacer or add a mask in children less than 4 years. Ipratropium can be used in addition to SABAs for a moderate to severe asthma exacerbation, and I also included the dosages there for you as well. For patients with mild asthma symptoms, oral glucocorticoid therapy is only indicated if the patient does not have symptom improvement after the first 2 doses of SABA therapy. However, if the patient is experiencing moderate to severe asthma symptoms, then that oral glucocorticoid therapy should be administered shortly after the initiation of the albuterol. Patients who present to the outpatient setting with mild to moderate symptoms that improve with therapy, they generally can be discharged home safely. Criteria for the referral to an emergency department, those include symptoms of respiratory distress, patients with a high risk for life-threatening asthma exacerbations, for example, those patients that have been intubated in the past due to their asthma, and then of course those who just do not improve with treatment. Up to Date had this super helpful chart that discusses the evaluation of asthma, signs and symptoms, and their associated level of severity. So I thought this would be really important to include. You can go over that. That will really help you in your triage of patients and whether or not they need to be transferred to the ER or if they can be managed properly in the outpatient setting. So go ahead and read that over because I think this is going to be ending the PowerPoint. All right, yep, so that's going to be it for today. Lots of information to digest. Don't forget to leave me any comments or questions down below that you might have. And as always, make sure to go ahead and subscribe to the channel and like the video. It is a free way to support the channel and help me to create more content like this. As always, you guys know I wish you the very best, and I will talk to you soon. Bye.